I'm going to move on to the studies at ASCO in the metastatic setting now, okay? And the first one is Keynote 789. So Keynote 789 was a phase 3 randomized study, and it was basically looking at patients that harbor an EGFR alteration, exon 19 or L858R with a good performance status, and they were randomized to get chemotherapy with immunotherapy or chemotherapy alone. And the main question here is, do patients with an EGFR mutation benefit from immunotherapy in this setting? So here are my thoughts. There was a trend in progression-free survival and overall survival. However, it was not statistically significant. Those with a PD-L1 positive disease may have had a slight benefit with a hazard ratio of 0.77 versus those with PD-L1 negative 0.91, but I'm not buying that. Stay tuned for chemoimmunotherapy and anti-angiogenesis agents like bevacizumab and ramucirumab in this space, as there may be some activity, but it's questionable. So long story short, this was a negative study in my mind. It did not show that immunotherapy helps patients in this setting that have EGFR mutations. So even though this was a negative study, it's important to talk about negative studies because that's how we learn as well. So I don't think this was practice changing for me. Now let's move on to Everest. So Everest was another study that was presented at ASCO. It's a randomized phase 3 study of first-line zorifertinib versus gefitinib or alatinib in EGFR mutated non-small cell lung cancer patients with CNS metastasis or brain metastases. Remember, I told you that's a buzzword I always look for. So let's talk about this study. These patients had stage 4 disease, they harbored an EGFR mutation that was driving their disease, and they had brain metastases that were asymptomatic. So what did we find? We found that there was an improved progression-free survival of zorifertinib compared to gefitinib or alatinib. The PFS hazard ratio was 0.7, and the intracranial progression-free survival hazard ratio was 0.467, so even better. And interestingly, those that harbored an L858R alteration had a slightly greater benefit. That's EGFR exon 21. And typically, patients that have L858R alterations compared to exon 19 deletions have a slightly more aggressive disease. So anytime I see a benefit for L858R patients, I feel like that's a little bit of a win for me, and I get a little excited. But cut to the chase, my thoughts. I don't love that this study compared zorifertinib to gefitinib and erlotinib. I wish they compared it to osimertinib. I think it would have been a little bit more up to date. I know that's not possible all the time, but I don't love the comparator arm. I think it could have been stronger. There was a lot of toxicity, unfortunately, that required dose reductions. So my question is, if we're reducing the dose of zorifertinib, is the drug penetrating our CNS? Is it getting past the blood-brain barrier and treating those brain metastases? Unclear to me. There may be an option for zorifertinib where osimertinib is not available, because I know it is still not readily available across the world. But stay tuned. Now we have Symphony, which is also known as Blue 945. Here is a brief schema. Basically, these were patients with stage 4 disease harboring an EGFR mutation, and they were randomized to get Blue 945 as monotherapy or Blue 945 plus osimertinib. So cut to the chase. Blue 945, what is this drug? This is a 4th generation tyrosine kinase inhibitor. So we have 2nd generations erlotinib, gefitinib, we have 3rd generations osimertinib, and now we have this 4th generation Blue 945. And the thought is that the more developed we get, the more refined the tyrosine kinase inhibitors are. So we noticed that there was a lot of toxicity, transaminitis, fatigue, nausea, vomiting, hyponatremia, unfortunately, with this study. And while there was tumor shrinkage, it's still not ready for prime time. So the combo is safe, Blue 945 plus osimertinib, and there's further development moving this into the frontline setting. So take-home messages from today. Adjuvant osimertinib, based on the ADAURA data, does have overall survival advantage, right, for stage 1B to stage 3A. There is no clear role for immunotherapy in the EGFR space yet. Zorifertinib is not clearly superior to osimertinib, as it was compared to gefitinib and erlotinib. We need a better comparison arm, as I had said. Symphony Blue 945, the 4th generation tyrosine kinase inhibitor, curious about its efficacy in the frontline setting and its efficacy when combined with osimertinib. We still don't know what to do post osimertinib. So if your cancer grows on OC, I still don't have the perfect answer for you, but look for resistance alterations, and there is more work that needs to be done in this space. So long story short, lung cancer is complex. One size does not fit all, and it gets more complex as the day goes on. So advocate for yourself, ask questions, attend these conferences, and just know that we're here for you. I put my name on there. I put my email on the front. I welcome emails. I welcome messages. I hope to hear from you. I'm your advocate. Thank you so much, Cancer Grace, for having me and inviting me back. Thank you to my MSK team, and of course to our patients and their caregivers.